Rupture of an intracranial aneurysm has dire consequences. Usually, the bleed is subarachnoid. In some cases, it might rupture the arachnoid and become subdural. The management is fraught with difficulties, and ultimately, obliteration of the aneurysm is aimed for. Endovascular management and surgical management are both proven to be effective. The choice between these two varies from center to center, from aneurysm to aneurysm. The degree of expertise in each of these procedures is probably more important in the outcomes than the choice of the management. Blood supply to the brain can be divided into the anterior circulation and the posterior circulation. The anterior circulation is also called the carotid system. We have two internal carotid arteries. The posterior circulation is also called the vertebro-basilar system. The anterior circulation, as we said, includes the carotid artery, right and left. The first intradural branch of the carotid artery is the ophthalmic artery. Then we have the posterior communicating artery and the anterior choroidal arteries arising very close to each other. The posterior communicating connects with the posterior cerebral artery, and the anterior choroidal artery supplies vital structures. Bifurcation of the ICA, or the internal carotid artery, occurs soon thereafter into the anterior cerebral artery and the middle cerebral artery. This point is called the ICA bifurcation. The anterior cerebral artery continues till it gives off a communicating branch to the opposite anterior cerebral artery, completing the anterior aspect of the circle of Willis. Continuation of the ACA, we have frontopolar branches and also calloso-marginal branches, which can also be the origin of aneurysms. The middle cerebral artery, after it arises from the ICA, travels through the sylvian fissure to bifurcate into two, or sometimes it's a trifurcation to three branches. Occasionally, MCA branches beyond the bifurcation or trifurcation may be the site of aneurysms. Posterior circulation is constituted by the vertebro-basilar system. The right and left vertebral arteries arise from the subclavian artery. They enter the cranial cavity through the foramen magnum. They soon give off, one on each side, posterior inferior cerebellar arteries, or the PICAs. After this, the two vertebral arteries unite to form the basilar artery. The basilar artery ascends in front of the brainstem. The next branch is the anterior inferior cerebellar artery, again one on each side. Above, we have superior cerebellar arteries, one on each side. Just above this, the basilar artery bifurcates. This location is called the basilar top. Posterior cerebral arteries arise from the basilar bifurcation. Posterior cerebral arteries are now connected to the posterior communicating artery, which we have already said arises from the internal carotid artery to complete the circle of Willis. Aneurysms occur at branch points of the circle of Willis. The direction of growth of an aneurysm reflects the flow pattern where the jet of blood or the stream of blood is headed. The direction of rupture and the direction of subarachnoid blood also reflects, to a certain extent, the direction of blood flow. Intracranial aneurysms are relatively common and affect between 2 and 3% of the population, of the adult population. Some of these aneurysms may be incidentally detected while screening for other problems. Classical presentation of an aneurysm is by subarachnoid hemorrhage, when an aneurysm ruptures and bleeds. Subarachnoid hemorrhage due to aneurysm rupture is characterized by sudden severe headache associated with nuchal stiffness or neck stiffness. Some aneurysms classically produce cranial nerve palsies. Third nerve palsy can occur because of a laterally pointing posterior communicating aneurysm. Ophthalmic aneurysms may result in blindness, especially when bleeding occurs. As the bleeding becomes more severe, consciousness is affected to various degrees. The degrees of subarachnoid hemorrhage severity have been quantified by the Hunt and Hess scale and by the World Federation of Neurological Surgeons scale into scales 1, 2, 3, 4, and 5, 1 being just headache and 5 being a moribund patient. Giant aneurysms may sometimes present with mass effect. They also might produce embolic phenomena as clots inside the aneurysm and re-enter the circulation. What are the pathophysiological consequences of an aneurysmal subarachnoid hemorrhage? The moment an aneurysm ruptures, there is a protective vasospasm. This is protective because otherwise continued bleeding into the cranium is not compatible with life. Inflammatory cascades, often disproportionate to the quantum of blood in the cisterns, occur. There may be seizure phenomena, some of it clinical, some subclinical. The intracranial pressure now rises. There is a cerebral circulatory arrest, which might occur in severe cases of subarachnoid hemorrhage. The danger at this period is that immediately after the immediate vasospasm passes off, the patient might develop a rebleed, which is very morbid and which has got a mortality rate of about 60%. 2 to 3 days after the subarachnoid hemorrhage, we have the period of delayed cerebral vasospasm. It starts at day 4 and goes on for 3 weeks. The vasospasm is often severe enough to produce delayed ischemic neurological deficits. Electrolyte disturbances may occur. They might be SIADH, syndrome of inappropriate ADH secretion, or cerebral salt wasting, both of which result in hyponatremia. They might also be, in more severe cases, diabetes insipidus. Systemic and metabolic derangements often accompany an aneurysmal subarachnoid hemorrhage. There may be hyperglycemia. ECG changes, including ST segment depressions, often occur. How do we investigate a case of aneurysmal subarachnoid hemorrhage? A CT brain is the initial investigation. Basal subarachnoid hemorrhage is seen. Like clinical grading of subarachnoid hemorrhage is into Hunt and Hess or World Federation of Neurological Surgeons grades. The severity of bleed on CT is graded by the Fisher grades, depending upon the quantum of blood in the systems, the location, and also the presence or absence of intraventricular blood. Some aneurysmal ruptures can result in intracerebral bleeds. MCA aneurysm rupture can usually produce a temporal hematome or sometimes a frontal hematome. Gyrus rectus bleeds may occur with aqueous aneurysms. Large aneurysms may be seen, their outline may be seen on a CT scan. Delayed CTs will show infarcts and hypoperfusion because of vasospasm. As ICP rises, herniations may be manifest. MRI with MRA will show the cerebral vasculature. A CT angio may demonstrate aneurysms both ruptured and unruptured. And digital subtraction angiography shows us the flow patterns, which are invaluable when we plan management. How do we manage aneurysmal subarachnoid hemorrhage? A patient with high-grade subarachnoid hemorrhage will have a low GCS and will require intubation and ventilation. Even a person whose Glasgow Coma score is at the borderline is often preferably intubated and ventilated because sedation is often required for these patients because of the headache, and we don't want them to struggle. And we want to have tight BP management, which is facilitated by elective ventilation. The primary aim of an aneurysmal subarachnoid hemorrhage management is to prevent a rebleed because rebleeds have a very high mortality. A systolic BP target of slightly less than 150 millimeters of mercury is kept for a ruptured aneurysm. Soon, by day 3, the patient might go into vasospasm, and one of the things that can trigger vasospasm is hypotension, along with, of course, blood in the subarachnoid systems. Nimodipine acts as a cerebral protective. It also decreases the incidence of cerebral vasospasm and of brain damage. BP maintenance, maintaining the blood volume, and maintaining a low hematocrit were part of the old Triple H regime, which is now no longer followed. Cerebral protection is offered. Anti-epileptic drugs are useful for this, and sedation also is useful for this. Optimal oxygenation is done. Electrolyte disturbances are corrected. Relief of pain management is important in patients who are not ventilated and electively ventilated. And NSAIDs are usually avoided for relief of pain. Definitive management to prevent a rebleed is started upon as soon as feasible because, as we said, rebleed in an aneurysm can be associated with a very high mortality. There are two primary methods of tackling a ruptured aneurysm to prevent a rebleed. One is surgical clipping of the aneurysm, and the other is endovascular coiling. Surgical aneurysm clipping is usually done through a pterional approach, which gives us access to the circle of Willis, right from the anterior communicating complex back to the basilar top. In some aneurysms, other approaches may be required. A frontal interhemispheric approach may be used for some DACA or distal anterior cerebral artery aneurysms. Retromastoid craniectomies with some drilling may facilitate surgical approach to a pica aneurysm. So the approach usually is transsylvian, and this involves a sylvian fissure split, which is an essential surgical skill for a surgeon tackling cerebral aneurysms. What are the principles of surgical management? The first is we have to soften up the brain. Soften up the brain means we drain CSF. This can be done by an external ventricular drain. It can be done at the time of surgery. Occasionally, a lumbar drain may be put. A third ventriculostomy is often possible when we are trying to tackle an anterior communicating artery aneurysm. All these measures allow the brain to become softer, and the opening of the sylvian fissure permits frontal lobe retraction without trauma. Now that we have softened the brain, the next step is to soften the aneurysm. How do we soften an aneurysm? By decreasing the pressure, by decreasing the blood pressure. We also try to protect the brain by giving cerebral protective regimes or brain protection cocktails. Actual mechanical softening of an aneurysm is achieved by proximal control, that is, from the direction of blood flow, and temporary clip may be used. In an MCA, a clip on the proximal MCA will decompress an MCA bifurcation aneurysm and allow for its dissection. In most other aneurysms, blood flow is dominantly from one artery, but also contributed by the opposite side or by the posterior circulation. In an ACOM aneurysm, clipping and the softening before clipping often requires placement of two clips, one on each anterior cerebral artery. In a pica aneurysm, the vertebral artery is clipped both proximal and distal because otherwise retrograde flow through the vertebral artery is as vigorous as flow from the ipsilateral vertebral artery. The primary endovascular procedure for tackling an aneurysm is aneurysm coiling. Detachable coils are packed into an aneurysm to provoke thrombosis and obliteration of the aneurysm lumen. Some aneurysms are difficult to coil. If the neck of the aneurysm is wide, then coils do not stay inside the aneurysm, they tend to slip out. So for that, we have coils with stems. Some aneurysms where coil placement and retention is impossible may be managed by flow diverters, which prevent the jet of blood from impinging upon the fundus, causing ruptures and increase in aneurysm size. How do we choose between clipping and coiling? There are a few advantages of clipping. You can evacuate clots. You can wash out the subarachnoid hemorrhage. You can drain CSF. And there is an option of decompressive craniectomy in case the brain is tight. What are the advantages of coiling? Coiling is less invasive. A swollen brain does not create so many problems for the endovascular interventional radiologist. Ultimately, the choice between clipping and coiling depends upon economic factors, on the expertise available, and the patient's general health. Clipping is much cheaper than coiling. The costs are about 1/3. Even with coils alone. With flow diverters, the cost goes up much more. Expertise is very important. A very experienced aneurysm surgeon can tackle most aneurysms very safely. And a very experienced interventional radiologist can coil most aneurysms safely. The surgical or endovascular expertise directly impacts the outcome of aneurysm management. Institutional experience also matters. It has been shown that institutions which tackle fairly large volumes of subarachnoid hemorrhage have better outcomes. This involves probably both individual expertise and also the management team.